everyone. I am Dr. Prateek Singh Bhadoriya, DM cardiologist from the city of Gwalior, and I am here with you all today to discuss the management of hypertension in diabetes. And this is according to the RSSDI guidelines 2022. As we all know, hypertension and diabetes are two of the leading lifestyle diseases in the Indian and South Asian populations that often coexist due to overlapping pathophysiological factors. Obesity, insulin resistance, inflammation, and oxidative stress are thought to be some common pathways. Up to 50% of hypertensive cases in India are diagnosed with type 2 diabetic mellitus. The recent guidelines, that is 2022 guidelines, provide comprehensive recommendation for managing hypertension in patients with diabetes. As per the Indian guideline of hypertension 4, IGH4, hypertension is defined as a systolic blood pressure of more than 140 or a diastolic blood pressure of more than 90 mm of mercury. Primary hypertension is mostly asymptomatic, while secondary hypertension is due to various underlying pathologies. Uncontrolled BP, despite the usage of 3 antihypertensive drugs, is referred to as resistant hypertension. Over 1 billion people suffer from hypertension globally, which is expected to rise up to 1.5 billion by 2025. Up to 50% of cases of hypertension are also diagnosed with type 2 diabetes. Hypertension presents as a major risk factor for heart failure, cardiovascular disease, chronic kidney disease, peripheral artery disease, erectile dysfunction, and organ damages. There is a complex cause-effect relationship between hypertension and diabetes, which predisposes the patient to increased risk of cardiovascular complications. For patients with diabetes and hypertension, 24-hour ambulatory blood pressure monitoring is recommended to maintain target BP of 120 to 130 millimeter of mercury systolic. The use of an aneroid sphygmomanometer must be preferred over digital devices. However, digital machine may be preferred for home-based measurement. Blood pressure thresholds vary with age and comorbid conditions. Non-pharmacological management of hypertension in diabetic patients, like lifestyle modifications, may delay the need for pharmacological interventions or can complement the BP lowering effect of many drugs. A low sodium diet, increase in physical activity, and a healthy diet are recommended to manage hypertension in all patients. Pharmacological management of hypertension in diabetic patients, ARBs are recommended as the choice of therapy, preferably in combination with calcium channel blockers to manage hypertension and resulting complications. For combination therapy, newer calcium channel blockers like cilnidipine along with ARBs are recommended. Cilnidipine is a novel, effective, and safe CCB which is established for its protective benefits. Combination therapy of ARBs with thiazide-like diuretics also reduces the risk of renal disorders. While telmisartan can be the first-line ARB for treatment of diabetic hypertensives due to its beneficial effect on fasting blood glucose and insulin levels, alternatively, azlisartan with a similar safety and efficacy profile is also recommended. Thiazide-like diuretics can be preferred in elderly patients with existing CVDs. ACE inhibitors may be used as an alternative to ARBs for CVD risk reduction in high-risk patients. Beta blockers may be preferred in patients with a previous history of CVDs and as an alternative to RAS blockers in pregnant patients. To summarize, hypertension is a strong modifiable risk factor for the macrovascular and microvascular complications of diabetes. Strong evidence from clinical trials and meta-analysis support targeting blood pressure reduction to at least 140-90 mm of mercury in most adults with diabetes. Lower blood pressure targets may be beneficial for selected patients with high CV risk if they can be achieved without undue burden, and such lower targets may be considered on an individual basis. In addition to lifestyle modifications, multiple medication classes are often needed to attain blood pressure goals. I thank you all for your patient hearing.